In a fast-paced clinical or emergency setting, a focused 5-minute point-of-care ultrasound assessment of right ventricle is invaluable. Because the right ventricle is highly sensitive to afterload and preload and has a complex crescentic geometry, a multi-parametric approach is necessary. Here is a streamlined protocol to assess right ventricular function efficiently. 1. Visual assessment and dimensions. Start with the apical 4-chamber view to gauge the big picture. RV-LV ratio. In a normal heart, the RV should be about 2/3 the size of the left ventricle. Mild dilatation, RV is larger than 2/3 but smaller than the LV. Severe dilatation, RV is larger than the LV or forms the apex of the heart. McConnell's sign. Look for akinesia of the RV free wall with sparing of the apex, a classic, though not pathognomonic, sign of acute pulmonary embolism. 2. Longitudinal function, TAPSE, tricuspid annular systolic excursion. Longitudinal contraction accounts for the majority of right ventricular stroke volume. Use a mode in the apical 4-chamber view. Place the cursor along the lateral tricuspid annulus. Normal is more than 17 mm for TAPSE. TAPSE is highly angle dependent. Ensure your cursor is almost parallel to the right ventricular free wall motion. 3. Radial function, fractional area change, provides a global estimate of right ventricular systolic function by comparing end diastolic and end systolic areas. Fractional area shortening is right ventricular area in diastole minus right ventricular area in systole, the whole divided by right ventricular area in diastole and expressed as a percentage by multiplying with 100. Normal threshold is more than 35%. If the right ventricular endocardium is difficult to see, focus on visual eyeballing of inward wall motion in the parasternal short axis view. 4. Pressure overload, the D sign. Switch to parasternal short axis view at the level of the papillary muscles. Septal flattening. In states of RV pressure or volume overload, the interventricular septum flattens, turning the left ventricle from an O shape into a D shape. Diastolic flattening suggests volume overload. Systolic flattening suggests pressure overload as in pulmonary hypertension. The subcostal long axis view of the inferior vena cava serves as a proxy for right atrial pressure. If IVC is small and collapsibility is good, estimated right atrial pressure is normal. On the other hand, if IVC is dilated and collapsibility is less, then right atrial pressure is elevated. Here is a quick summary. Is the right ventricle bigger than the left? Then right ventricle is dilated. On M mode, if TAPSE, tricuspid annular plane systolic excursion, less than 17 mm, there is systolic dysfunction of the right ventricle. Parasternal short axis, is there a D sign, that is LV having a D shape, there is pressure or volume overload of the right ventricle. In subcostal view, is the IVC plethoric, that indicates right atrial pressure is high with congestion, systemic venous congestion.